went to medical school at the Medical College of Virginia before doing his internship and residency in internal medicine at the University of North Carolina, Chapel Hill. He also stayed there to do fellowships in pulmonary medicine, critical care, and sleep. So Dr. Biscardi is the medical director for a couple of our sleep labs and our sleep center, and he's going to come speak to us now on some sleep problems. And as I said earlier, sleep is a major issue in mental illness. And one of the first things that we do when a patient presents for us with any kind of medical illness is to address their sleep issues.
The noise we're hearing is upstairs somewhere. We've got someone trying to locate that, so pardon that. Okay. Need to load that up?
Yeah, I made some changes.
Okay. Let's see. Let me make sure that's turned on first, or it's not muted. Okay, you're good. I'll go ahead and clip this up for you. Let's do it this way. Okay.
It's added SMA presentation.
Okay.
Okay, thank you. Well, I'd like to thank the Southern Medical Association and Dr. Kilgus for inviting me to come and speak today to you about primary care issues in obstructive sleep apnea. And the nature of my talks changed over the last 6 months as I've thought about giving this talk, because there have been some changes in the way that services for sleep-disordered breathing is going to be handled in the future. It's been driven by financial issues, and a lot of this is going to mean pushing sleep disorders out of the specialist clinic and more into the primary care clinics. How many people here are primary care? Great. We have any sleep people? No? Okay. So I thought we'd go over this today. I have no conflict of interest. And just a quick review of sleep apnea. As many of you know, it's a mechanical problem that occurs in the upper airway. Normally, the pharyngeal dilators are innervated by branches of the phrenic nerve, so that when you inhale and you produce a negative pressure in your chest, your pharyngeal dilators become more rigid. When you lay down, there are gravitational issues that want to close the airway, and as you fall asleep, you lose muscle tone. When you go into the stage of sleep where you dream, you actually become atonic in all your skeletal muscles except for your sphincters and your diaphragm, and you lose upper airway tone. And then when you breathe in and the pressure in the airway becomes subatmospheric, the airway wants to close. And you know the symptoms. People will tell you that their spouses stop breathing at night. They complain about snoring, waking up at night, gasping and choking. Because of the sleep disruption that comes when people have obstructive apneas, they have to actually wake up, take a breath or two, and go back to sleep. These brief arousals cause non-refreshing sleep. People tend to have very fragmented sleep during the night, and it causes them to have morning headaches from hypoxemia and cognitive issues that come from chronic sleep deprivation. You know, sort of the post-call kind of feeling you get where you can't concentrate and your memory's bad and you get a little irritable and you snap at the nerves, as you shouldn't do. It's not just about snoring. Snoring is bad and it annoys other people, but it doesn't necessarily hurt you. And the way that we correct sleep apnea, as Dr. Pell was talking about earlier, is with continuous positive airway pressure. And this is delivered through a mask or some interface that just pressurizes the airway so the airway won't close. It's very important. There are all sorts of comorbid illnesses that come with sleep apnea, and you really shouldn't miss it in your patients, not only because it makes them feel rotten, but because it complicates some of the other things you're trying to fix. There's lots of literature about these comorbid illnesses. I'll just show you a few things to illustrate. If you look at people who have untreated sleep apnea over long periods of time, they tend to develop hypertension, with people with severe sleep apnea developing at a much higher rate than the general population. This has been shown over and over again, and the people with the worst hypertension typically have the worst sleep apnea. Coronary artery disease also gets worse as you has worse outcomes if you have untreated sleep apnea. Now, this is fatal cardiac events. This is non-fatal cardiac events. And if you look at the incidence of sleep apnea, the red line is severe sleep apnea. There certainly is a big mortality change between people with sleep apnea and people who are normal or just snore. With milder forms of the disease, there's less of a notable change. And it also is mirrored in non-fatal cardiac events. As you treat sleep apnea, the risk of the cardiovascular events decrease. And you can see with these Kaplan-Meier graphs that the percent survival improves if you treat sleep apnea and you have less, whether you have preceding heart disease or whether you don't. In patients with atrial fibrillation, Dr. Plaza was telling us about atrial fibrillation. If you look at people who present to the cardiologist with atrial fibrillation versus other disorders, the incidence of atrial fibrillation is much higher in people, the incidence of sleep apnea is much higher in atrial fibrillation than in other patients. And if you don't recognize it, you send them to the cardiologist, and the cardiologist does an ablation or does a cardioversion, the success rate is much lower in people with untreated sleep apnea. So this all becomes very important. So what is it about sleep apnea that hurts your heart? Well, it's the repetitive desaturations that occur. Now, this is a typical oximetry. From here to here is 1 hour. This is 90%. We don't really like to see people below 88. And what you see here is this very up and down change in oxygen saturation where someone becomes hypoxic and then reoxygenates. And that reoxygenation is what hurts you. And if you think about other things in medicine where people get reoxygenated, such as implanting a kidney that's been ischemic for a while, implanting a lung that's been ischemic for a while, taking a tourniquet off a leg where someone has had ischemia in the leg. There are free radical injuries that can occur with this. By the way, you see how this drops about every 90 minutes? This is classic oxygen changes in someone with REM-related sleep apnea. REM occurs about 5 times a night and is typically about 90 minutes apart. Reoxygenation is not your friend. He's not your friend. And if you get an oxygen molecule, you knock an electron off of it, you get a free radical, okay? Free radicals are bad. Free radicals zip through your blood vessels, hit your endothelial cells in your arteries. They oxidize lipids, and they peroxidize lipids, and they cause the release of cytokines, interleukin 1, interleukin 6, tumor necrosis factor. All these things go up in untreated sleep apneics, and they cause cellular injury. This sets up a whole cascade of problems that then lead to cardiovascular disease. So you have the oxidative stress that releases these cytokines and causes endothelial injury. Then what happens is the endothelial cells that are injured then release other chemicals like intercellular adhesion molecule and selectins, which cause white cells and lymphocytes to now attach themselves to this area of damage, including macrophages, which are full of lipid particles. And then you get the development of an atherosclerotic plaque. At the same time, we know that people with obstructive sleep apnea have sympathetic activation. If you look at a sleep study, when someone breaks an airway obstruction, there's always a tachycardia. These people have higher levels of circulating catecholamines, and they tend to become more hypertensive, as I showed you in one of the first slides. At the same time, for some reason, they get a metabolic dysregulation. They become insulin resistant. They hypersecrete insulin for the same amount of carbohydrate loads. So now you have somebody who's hypertensive, hyperlipidemic, elevated glucoses, elevated circulating insulin levels, and you end up with a nice atherosclerotic plaque just waiting to rupture. the cost of taking care of people with sleep apnea is really escalating. You all in 5 to 10% of the population have sleep apnea. And most of them, about half of them, are bad enough to treat. That's a lot of people. And you all in primary care have gotten better and better at recognizing people who have obstructive sleep apnea. And particularly for looking for it in certain groups, people who are really at risk for it, people who are overweight, diabetics, very old people. And our population is getting bigger, and we're getting heavier. And the incidence of this is going up. It's getting picked up more often. And this is a very expensive diagnosis to treat. A sleep study is about $3,000, depending on what market you're in. And often there's a second sleep study or a titration study. CPAP machine's about $2,000 the first year. I'm the cheapest part of the whole thing. But it gets very expensive. And I have this slide, I can't find it, but it shows an almost exponential increase in the expenditures over the last 5 years for sleep services. So what's happened is the third-party payers, the government, not only our government, but world governments, particularly places with socialized medicine like Australia and England, are funding research to try to find an alternative way to do this. Sometimes the data, sometimes it almost looks like the experiment is designed to try to do it a cheaper way. And I'll show you some of those. But because of this, they're looking for a way to get around this. And part of that's going to be by pushing it into your office. So I wanted to talk to you about ways you can do this, the right way to do it, things to avoid and look for, and some of the pitfalls of managing people after their testing. In this study, they looked at primary care providers versus specialist care for sleep. And it was a randomized trial. It was done in Australia. This is one of those governments that's got socialized medicine, and they want to show that you can do it cheaper. And they looked at, for their primary endpoint, was the Epworth sleepiness score. I'll explain that in a minute. And they compared this to a university sleep center that got the usual treatment like we do it here in the States. They also looked at compliance, costs, and quality of life. The Epworth sleepiness score is a very easy tool. You can use it in your office. As long as you have people who are being straightforward and honest with you, it's okay. If you use it on a truck driver who wants to keep driving no matter how bad he is, it won't work. And you basically just list how likely you are to fall asleep or doze in this setting, in these different settings, and you have the patient apply a number to it. And 10 is about normal, and less than 10 is clearly normal, and greater than 12 is clearly abnormal. And what they found in this study was that if you look at the Epworth sleepiness score, it didn't seem to matter whether the patient was managed by the primary care people or by the specialists. Now, there was an awfully high dropout rate in the primary care group for reasons weren't certain. Then they did this other study. I think this was also from Australia or from New Zealand, I forget which, and they looked at nurse-led care versus physician-specialist care. They had quite a large number of patients, although they sort of cherry-picked them and they came down to just a smaller number of people, really, there was a big dropout rate. And they screened them with oximetry to 2 arms, either getting a proper sleep study or getting a portable study and getting an automatic titrating device versus normal CPAP titration. And they looked at the Epworth score at 3 months. And what they saw was there was no difference in the Epworth sleepiness score, whether you're managed by the nurse or by a sleep specialist physician. There was no difference in compliance, and they found lower costs in the nurse's model. And the conclusion was a simplified nurse-led model of care was non-inferior. Now, what they didn't tell you was that the nurse wasn't just any nurse. She was a nurse who'd worked in sleep disorders for many, many years, and she had unlimited phone access to a sleep specialist to ask questions to. So generalizing this to your office or my office is not necessarily the case. But you go to the national sleep meetings, and some of the professors who have, under their disclosures, they show their list of corporate sponsors, and you see there are people who provide equipment for doing home testing, and it just, enough said, but nonetheless, it's being used as a reason why sleep should not be done in the specialist office, but should be done in your office. So where's it all going? There's a huge number of patients with untreated sleep apnea. There's all sorts of comorbidity associated with it. Third-party payers don't want the specialists doing it in the sleep labs and spending a lot of money. And the testing is expensive, and sometimes it's really not necessary to do the big test. This was actually a pretty honest approach at looking at the question about whether you could use portable equipment to do sleep study testing. A lot of it was driven by ENT specialists who wanted to be able to see their own patients, study their own patients. When they sent them to the sleep lab, they ended up with CPAP rather than operation. So there was a kind of a push there by ENT to try to get more portable studies. This was a good panel. Dr. Balick was one of my old professors from Carolina. And they looked at different types of equipment that are out there. And they broke them down into 4 categories. A level 1 is like a formal polysonogram. You've got a technician there who can fix everything that breaks, who can put on a very complicated montage of EEG and EMG, oxygen saturation, effort measurements, and can make changes depending on the patient's clinical state, can handle a really sick patient, can deal with arrhythmias, can deal with leads that come off. And this is what you get when you get an attended sleep study. You can also judge sleep stages. You can tell whether the patient objectively sleeps, and you can pick up other things like parasomnias, nocturnal seizures. It's a very useful test. Level 2 is basically the same thing, but at home without a technician, and these things never really work out too well. They're too complicated. Wires fall off. You end up with half a study. You can't read it. You end up repeating it. So they're sort of fallen out of favor. Level 3 studies are relatively reasonable studies. We use them in my facility. They're 4 channels. They pick up oxygen saturation, respiratory effort, and airflow at the nose. And it's really all you need if you have someone who just has straightforward severe sleep apnea. And level 4 devices are sort of screening devices, which are perfectly appropriate for you to have in your office and to use if you're not really certain whether the patient warrants a real referral or not. This is a full sleep study where you have electroencephalographic monitoring and eye movements to judge different sleep stages. You've got electrocardiogram. You get a free Holter monitor out of it. You get airflow and chest and abdominal movement. This is an Apnea Link. Has anyone got these in their office? You can lease these for a couple $100 a month, and I think you can bill $20, $30, $40 for doing one of these tests. And it's just an airflow thermistor, which measures airflow at the nose and oxygen saturation. And what it'll do is it'll tell you if the patient, I'm sorry that didn't come out, roughly how low the oxygen saturation goes, how long it was low. You can use it to qualify people for home oxygen. And it gives you a respiratory disturbance index, which is roughly the number of times a patient stops breathing divided by the recording time. It's not a bad thing to have in the office for a lot of reasons, and you can bill for it if you're in primary care. You can do it with just an oximeter, but there are lots of other things that cause this pattern of breathing. You could have Cheyne-Stokes respiration. You could have nocturnal hypoventilation. You could have all sorts of other problems that can cause this pattern of hypoxemia. It's not that specific. We use an Alice-type device, which Alice PDX. It's a brand name. There are lots of these. You can go out and Google them, and they're all, I'm not trying to promote one versus the other, but they give you respiratory monitoring, which is quite good. Some of them aren't so good. This is a device. It's called the Aries device. I'll show you some data on that. And it has a very nice validation study if you read the paper, but when you really actually look at the raw data from some of these devices, they're not that good. And you have to be kind of selective about what you're using or what the people are coming to your office to promote. And there are a lot of entrepreneurial groups out there that are seizing on this opportunity to do home testing and will come and provide you with a package where they'll mail this to the patient's house, they put it on, they send them the raw data, they interpret it, and they send it back to you. Some of them even offer where you can sign off on the report and bill for the interpretation of the test, and then they just, oh, by the way, we also sell DME, so I will take care of your DME for you, and then make a killing on the CPAP. Those are kind of arrangements you got to be a little careful about for stark reasons, and And you've got to know what you're looking at and what you're signing off on. So you want to make sure that it measures whether it says it's going to measure, that it has the minimal requirements, that you can review the data, and that you can make sure that they're actually scoring things according to Medicare guidelines of what constitutes an apnea, what constitutes a hypopnea. Do they use a 4% desaturation to call a hypopnea, or do they use a 3%? Because that's important, because if you do a 3% on a Medicare patient, that's fraud and abuse. And if you do a 4% on a Blue Cross patient, that's okay, but then Medicare is going to say, well, why are you using one criteria for these people and another one for us? That's fraud and abuse. So you've got to be a little careful about what they're calling what. So you've got this stable of patients. You've got 3,000 charts on the rack. Who are you going to think about having sleep apnea? Well, clearly people who are overweight. They're the easy ones. They've got big necks. They have congestive heart failure. We talked about atrial fibrillation. You should also think about treating people who, gosh, you got them on 4 drugs for hypertension, you just can't seem to fix her hypertension. Or the little old lady who you've given her diuretics and she's still got terrible leg edema, and you just can't get rid of the edema with the level of diuretics she can take. People who have a lot of arrhythmias, I'd encourage you to really think hard about people with pulmonary hypertension. And of course, if you're being asked to sign off on somebody's CDL card so that they can drive, and they've got this kind of pattern, you ought to be careful who you're signing off on, because that's not really a malpractice liability, that's civil if you sign off on somebody and they go out and have an accident. And certain other populations, people with upper airway surgery are at high risk if they have sleep apnea. You don't want to let them slip through. You should screen clinically, really. You should ask them the questions we talked about in the first couple of slides. You know, are you sleepy when you wake up despite a full night's sleep? Do you drift off to sleep during the day? Have you had car accidents because of it? And on physical exam, look for big neck size. This is the #1 risk factor for developing sleep apnea. And I've seen very thin athletic weightlifters come in who have 20-inch necks who have terrible sleep apnea. Body mass index, very crowded oropharynx, big tongue with a narrow mandible and tooth marks all the way around the edges of the tongue, tonsillar hypertrophy. And if you do pediatrics, if you see kids with adenoidal facies, with a lot of sinus disease, there's someone else you should look at. Some people are less obvious, okay? Dagwood snores all the time. He falls asleep at the desk. He can't wake up in the morning. And he's very micrognathic. And this is a sort of a phenotype that we see. I worked for a long time in Shenandoah Valley, Virginia, where there are a lot of people of Northern European extraction, especially Scotch, Irish, and German folks who had very short mandibles. And a lot of them weren't all that heavy, but they got sleep apnea because they just really had a short mandible, no place to put the tongue. The tongue is flexed back into the pharynx, and they tend to obstruct very easily, especially if they gain any weight at all. So don't just look for heavy people. So some of these companies will come to your office and say, hey, doc, you know, you've got all these hypertensives. Why don't you just screen them all? Should we do that? Well, sure, it's okay to screen them, but don't screen them with a testing device. Patients in high-risk settings should be screened only if they have a history that suggests obstructive sleep apnea. You're better off screening them with a questionnaire tool. It's a lot cheaper. You can do it as part of your yearly physical when they come in for their physical. You can just include a short questionnaire. I'll show you one in a minute. And the specificity of the portable tests can be poor under certain circumstances. Remember, the accuracy of a test is a function not only of the specificity and the sensitivity, but also in the pretest probability of who you're testing. So, for example, if you do an HIV test in a crack house and it comes back positive, well, that's probably a true positive, okay? If you do an HIV in a convent where everyone's celibate and nobody uses IV drugs and you get a positive test, it's likely a false positive, okay? So the accuracy of the test is a function of the pretest probability. The area system that I showed you earlier, this is from their validation study. If you look at people with very, very mild sleep apnea, the specificity in those patients is only 60%. So of every 10 positive tests, 4 will be false positives. And then you've gone and given that patient an expensive CPAP machine. They've got to wrestle with this thing every night. They have to pay for it, and you haven't done them any good. So you're much better off testing people who have more symptoms and not just screening populations. Here's an example. This was a study from the Journal of Clinical Sleep Medicine. I don't know why they published it, but they looked at family doctors who were screening with an Apnea Link. And they just screened everybody in the practice, and they came up with all their patients had an incidence of, prevalence of sleep apnea of 71%. Well, I just told you the population really only has a prevalence of 10%, and a lot of these have got to be false positives. Questionnaires are fine to screen with, and they don't hurt anything. This is a stop-bang questionnaire. You can just Google stop-bang, and it'll print up. And there's a list of questions: snoring, tiredness, observed apneas, hypertension, BMI. And if you add these up, and each one of these gets 1 point, if you've got 3 or 4 points, you've got an odds ratio of having sleep apnea that's pretty high. This is very useful. It's cheap, it's fast. You can make it as part of your yearly questionnaire that you hand out before they come in for their physical exam. Who shouldn't you study portably? Well, there are some people that even the experts agree who are advocates of this probably aren't appropriate for portable testing. First off, there are people who shouldn't be tested, have any kind of sleep testing, really. Is people with insomnia. You almost never find anything on polysomnography that's helpful. People with parasomnias, you can usually diagnose by history. Narcoleptics require a different sort of testing, and periodic limb movements is really a diagnosis that's reached by history. If you have someone who's going in and out of VTAC, it could be associated with their sleep apnea, and we've seen people who have apneas, long apneas, desaturations in the sleep lab who go into VTAC with it. And you put CPAP on them and the VTAC goes away. So those people shouldn't be at home getting tested. People who are hypercapnic, have chronic respiratory failure, severe COPD, there's no real evidence that you can test them portably and it's adequate or satisfactory. If there's a question of central sleep apnea or they have neuromuscular weakness or other neurologic problems, they probably ought to be in the sleep lab. We can also do an expanded montage and look for seizures too for you in the sleep lab. So you decide they need a sleep study. You send off a sleep test. This is sort of the report you get with a full night polysomnogram, very busy slide. Basically, you have sleep architecture, how much they slept, what stage of sleep they had, was it a good test, did you see them sleep in REM sleep on their back, and then it breaks it down into respiratory events, how many obstructive apneas. An apnea is cessation of airflow for 10 seconds, with or without desaturation. How many hypopneas you have. A hypopnea is a 30% decrease in airflow associated with a desaturation of 3 or 4%, depending on who you read. And they break that down into the apnea-hypopnea index. It also can tell you frequent periodic limb movements, whether the limb movements cause arousals. This is what you get from an ALICE. This is a level 3 device, and basically all it really gives you is oximetry data, and it gives you the number of obstructive or central events divided by the time that you recorded, and we call it the respiratory disturbance index. You'll see these two terms, they're not interchangeable. Apnea-hypopnea index is the number of apneas or hypopneas in an hour of sleep, and you can only tell that if you have a way to measure sleep, so you need the EEG, so that's only from polysomnograms. The respiratory disturbance index is basically the number of events divided by the recording time. The problem is if the patient doesn't sleep, they can either look worse or better than they are. I had one lady who had very clear symptoms of sleep apnea. I sent her home with a portable device because I thought it'd be appropriate. Came back stone cold normal. I called her up to talk to her about it, and she said, "Oh, I was up all night with a baby, walking around with this thing on my head." So inadequate sleep can make people look milder. Okay, so you've done your test now. You've got the report. Who are you going to treat? Clearly, there's a lot of evidence for treating people who are really, really bad. People who stop breathing more than 15 times an hour. And especially, we see people in the clinic sometimes. I saw one guy had 135 an hour last week. Amazing. Those guys need to be treated. Between 5 and 15, you typically treat people who have comorbidities. And there is some literature that supports treating them. It helps you take care of their hypertension, their diabetes, their AFib, their excessive sleepiness. The severity of your sleepiness has got nothing to do with your apnea-hypopnea index. Sometimes people with very, very mild sleep apnea can be extremely sleepy. And sometimes people with extreme sleep apnea get drugged in by their wives, and they don't know why they're there because they feel just fine. People who are less than 5, who are symptomatic, you can treat them with weight loss, decongestants. You can just tell them to stay off their back if they're worse on their back. There are oral appliances that you can use for sleep apnea which position the jaw forward. There is surgery for sleep apnea, which we typically discourage because it hurts, it costs a lot of money, and it only works about 50% of the time. Or to be more specific, it decreases the apnea-hypopnea index by about half. So if you have somebody who's pretty severe and you do surgery, they're still going to be pretty severe. If they're pretty mild, they mostly snore and they annoy their spouse, and you can go ahead and send them for that. So once you decide to treat them, what pressure CPAP are you going to use? Well, the classic thing to do is you have them come into the sleep center, you put CPAP on them, and you adjust the pressure up until they stop obstructing, they stop snoring, they stop having arousals. And then you prescribe a fixed mode. And this is a literature which is being pushed and funded by the people that make these automatically adjusting devices. And to be fair, some of them aren't bad. And what they do is the device looks at the uptake of airflow over time, and when the curve sort of, which normally has a roughly curve shape like that, when it starts to square off or starts to accelerate more slowly, the pressure is increased automatically. Some people have an arousal during that period of time and don't tolerate it because they end up having arousals even though they don't have frank obstructions. Now, this is an old study, but there have been plenty since then that show that if you use the automatic mode, that the compliance rates, the number of hours you use a night, is about the same. The pressure is typically a little lower, and the residual amount of sleep apnea is about the same. So the literature says that the automatic mode is about the same as having somebody on a fixed mode. Now, if you have somebody, just imagine your clinic. There are people in there you probably couldn't just give a machine, tell them to take home, put it on their nose, and it's going to adjust themselves. I mean, in the sleep lab, you've got a technician. She can change the mask types. She can change the humidification. She can adjust pressure. She can help the patient if they get flustered. And you don't get that with an automatic device at home. But most of the insurance companies are going to say, unless the patient was very hypoxemic during the night or had some other medical complication, has to get an automatic mode, automatically adjusting CPAP, and cannot come into the sleep lab for a titration study. Now, you've got to get all this paid for. The Medicare rules say that before you send the patient for the sleep study, you have to have a face-to-face meeting with the patient, and you have to document the Epworth score, the neck circumference, vital signs, physical exam, whether the patient's excessively sleepy during the day, and comorbid conditions. And that's got to be in the note. And if you don't have that, you can't prescribe the DME. And then between 30 and 90 days, you have to see the patient back in the office. You have to document they're symptomatically improved, that their apnea-hypopnea index is closer to normal, and that they've used the machine for more than 70% of the night for 4 hours. Well, how do you tell that? Well, you can ask the patient, but often they won't be straightforward with you because they want to keep the machine. So you get a compliance download. There's a chip in the back of the machine. They can download this, and the DME company can fax you this. This shows the number. These are nights, and this is whether they wore CPAP and for how many hours. This is hours here. And then they'll give you days with usage, and they'll give you the number of percentage of days with usage greater than 4 hours, 76%. And it'll give you the pressure and the apnea-hypopnea index on the CPAP. And this can be very helpful for troubleshooting, too. It often will show you a leak, whether there's a big leak. So you've got your machine to your patient, and then they come in and they say, "Doc, I can't wear it," or "I hate this thing," or "It's kind of okay, but I have this problem with it." How do you troubleshoot it? Well, the biggest problems are they'll tell you their nose is too dry, their nose is too wet, that the thing leaks, that it hurts them, it's blowing in their eye, they wake up breaking wind from both directions, and they feel smothered. Some people never have any problems with CPAP. Other people hate it. If you're doing really well, the compliance rate's about 60%. How do you deal with nasal dryness? Well, the good Lord gave you your nose to hold your glasses up and to act as a humidifier and heater. And when you inhale, the air that gets to your vocal cords is usually 100% humidified and body temperature. That's when you're sitting there breathing about 5 liters per minute, though. The CPAP machine blows about 20 liters per minute. If you have a leak in the system and the machine senses the leak, it'll increase the flow further to stop the leak, and that causes even more dryness. And it's just too much for your nose to humidify. So there are different types of humidifiers. This is just a passive, pass-over humidifier where you pass air over water, and it picks up some humidity. They work much better than nothing. And these are heated humidifiers, sort of similar to what you see on ventilator circuits. And by heating the water vapor, you get more water vapor in the air. So this is high school physics. If you have temperature here and vapor pressure of water over the fluid, as you heat the fluid up, the water vapor increases. So heated humidity works better, but the problem is if you heat it up too much, it then cools in the tubing, and the patient will say, "Doc, I wake up with a mass full of water like I'm drowning." What's happened is all that vapor is condensed in the tube, and some people will just stop using it because of that. In Franklin County, where I live, in Virginia, they make some of that condensate out in the woods. But it's the same thing. It's a still. You're heating up the liquid, it's cooling in a tube. You're heating up the liquid, it's cooling in a tube. How do you fix it? Well, you can turn the heat down, but then their nose dries out. Or you can insulate the tube, okay? And you can have them make a little cloth sleeve for it, and that keeps the tube from cooling off, and they don't get that problem. Nasal edema can come from too much heat or not enough heat, so you tell them to adjust the machine one way or another until they feel better. Some people get vasomotor rhinitis. You know, these are the people whose nose runs when they have a cup of hot soup or something. They're very hard to fix. Sometimes nasal atrovent will work on that. And nasal atrovent will dry your nose out for pretty much any reason why you have a damp nose. Allergic rhinitis you need to treat, and chronic infections. These things leak sometimes, and they leak because they try to put the same mask on everybody, and you can see noses are different. And there are all sorts of different interfaces. Nasal pillows, some people like those. Some people will prefer a nasal mask, and for some people, particularly mouth breathers, a full face mask is much easier. With a nasal mask, if your mouth opens up, then you've got 20 liters of air coming out of your mouth a minute, and it's quite spectacular, and sometimes you'll need a chin strap when people tell you, "I wake up, my mouth is just incredibly dry." And some of the options actually get kind of bizarre. There's probably 30 different masks out in the market. And this is too much for you to deal with in the office. So what you want to do is form a liaison with 2 or 3 really good durable medical goods companies that can work with you and change these masks and help people. And we actually keep in our office, we try to spread the business out, and we try to put all the DME companies on there that the patients like. If there's someone that doesn't give good service, they get taken off the list. But they're very helpful. And we also have technicians who can help with this and help with other problems like claustrophobia. There's a drill. It's kind of like, I guess the psychiatrist would call it flooding. There's a way that we can help people who are a little claustrophobic with systematic desensitization. Other causes for leaks can include just really high pressures. I had a fellow the other day who was on about 25 centimeters of water inspiratory pressure and about 18 of expiratory pressure, and it just an amazing amount of pressure. You could ventilate somebody on a mechanical ventilator with that. Nasal obstruction, you know, you've got to check for things like polyps and bad allergic rhinitis. Some people who've had bad nasal fractures and deviated septums just can't use nasal devices, and you have to use an oral mask. Positional problems, the mask that comes off every time you turn your face into the pillow. There are special pillows for that. So you just have to work with people through these problems. A sense of smothering or a need to take the mask off is often because the pressure is set too high or too low. And you may need to readjust the pressure either by doing another auto titration or by putting them in the sleep lab and readjusting pressure in the lab. BiPAP is, CPAP is continuous positive airway pressure. BiPAP is actually a trade name, and what it represents is 2 levels of pressure. So that, say you need 15 centimeters of water pressure to keep your airway from closing when you inhale, well, when you exhale, you don't need that much. So the machine will drop the pressure as much as you like, 5, 6, 8 centimeters of water pressure. And that makes it really much more comfortable. You're not breathing out against this big force. As Dr. Pell said, if you don't give people enough flow when they want it, they'll just go absolutely crazy. And there are ways to adjust flow rate with CPAP. And you've got to be supportive of your patients. It's easy to scold them when they don't wear it, but it's not always easy to wear. You've got to tell them not to get discouraged and to ask for help and not to just put the thing in the closet, because that doesn't do anybody any good. So how much of this is going to end up permanently in your office along with everything else? And it's not bad that it ends up in your office. It's not particularly hard to do. It's hard to do when the patient comes in for a 15-minute appointment and already has 4 or 5 problems. I did primary care too, and I know how that goes. And they usually mention these things as they've got one foot out the door. Oh, by the way, doc, I stopped breathing at night. It just takes time. There are courses you can go to if you want to. You can actually use this as a revenue source in your office if you want to do some of this. I'd rather you do it than some proprietary DME company doing it. The pendulum's going to swing back and forth a little bit. Is it really cheaper to give somebody an auto CPAP device when they cost an extra 50% more than a regular fixed CPAP? Does portable testing really save money if you start screening people who shouldn't be tested, and now you've got false positives, and these people all end up with a $2,000 machine? Will there be more treatment failures when you're not meeting with people who have the time to sit down and go over with you all these problems, all these nuisance issues, which have simple problems? They're just not simple solutions. They're just not self-evident. How many people are going to fall through the cracks? And then you think about all the comorbidities that go with the untreated problems. Is portable testing here to say, yeah, I think it's perfectly reasonable to do in people who are pretty severe and pretty obvious. But I don't know where all this is going to end. They're sort of trying to dismantle the specialty. And in many places, they're succeeding. I think in Maine, after they came out with some of these, there were 12 sleep labs, they all closed. My sleep lab's probably lost 30–40% of its income. And what's best for the patient is what's best for the patient. And I think it is reasonable to do some of this. But I just wanted to present this to you because I have a feeling that you'll be seeing more of it. Any questions? Okay. Well, thanks again for asking me to come speak.